just DNA.
Okay.
All right, so we just have a couple more that I want to talk about, and dofetilide or Ticasin is one that we'll probably be seeing more of, but patients have to be admitted to the hospital in order to start Ticasin, and if they've been off of it for a period of time or increasing a dose, they also need to come in for a 3-day period to be monitored, and the reason is because all of these agents can cause QT prolongation, but specifically with this agent, there is a very high risk, and there's actually a risk evaluation and mitigation strategy in place, a REMS program in place because of this risk. So anybody who's started on Ticasin or again here for a dose increase will need an EKG right away and then a BNP right away for us to look at potassium levels and serum creatinine levels for dosing, and the EKG also for dosing. Patients can't be started on this medication unless their QTC is below 440. This is EP will usually, weigh in and say if they believe that it's safe, if it's, close to that cutoff. But below 440, typically, unless they have ventricular conduction abnormalities, and then it would be below 500. So then, after a dose is given, and so these are very time-sensitive medications, but after a dose is given, 2 hours later, an EKG is to be repeated. And if that QTC increases above 15%, then the patient can no longer be on Ticasin or dofetilide. So very close monitoring that we do. And beyond that, after the first dose, we still do EKGs 2 hours after each dose. But after that first dose, if the QTC is above 500 at any point, or above 550 if they have ventricular conduction abnormalities, then again, the patient would not be a candidate for this medication and we would have to stop it. And again, EP will usually be on board to weigh in to say if maybe they're borderline and it's still okay to continue, but those are the manufacturer recommendations. So this is a twice daily medication. Again, very time sensitive with EKGs 2 hours after every dose, and the patient will have to stay in the hospital until 6 doses and 6 EKGs have been done. And the patient is going to have to be on continuous telemetry as well. So there is a policy that's under Pulse, and there's a lot more stuff directed towards pharmacy in the policy, but if you're interested or if you ever have questions about it, it is available on the Pulse website, and it has a list of providers that are available or certified to prescribe the medication and all of this information under treatment guidelines. So if you ever forget or have questions, well, your pharmacist, Tisha, will be available for questions. But you can also refer to that website as well. Other questions about dofetilide or Ticasin?
I guess I'll ask mine now. I'm supposing just what are we finding as far as the effectiveness of this? Because obviously hospitalizing someone for 3 days, putting them through this, I mean, I'm assuming that the benefit-risk ratio is just got to be good for us to continue seeking, continue using this for patients. So are you able to speak to that a little bit?
So this medication is much better tolerated in regards to side effects. So like it's in the same class as amiodarone. It is more selective to its inhibition of potassium channels, whereas amiodarone has a lot of other mechanisms of action, and it also has a lot more side effects. And so dofetilide or Ticasin is a lot better tolerated, and from what I've seen, people tend to do pretty well on Ticasin. I'm not sure.
Well, very good points. It is a cleaner medication compared to amiodarone. It is probably third most effective. If you take amio, you take flecamide, you take dofetilide for the rhythm control purposes.
And something I've heard of, sorry.
No, it's okay. We see many patients in heart failure where rhythm control is essential.
Mm-hmm.
And it's used also in conjunction with other beta blockers, right?
Not necessarily this one. The 1C category, those are just because of how they function. But no, it's not.
Because I had a patient who was on that and metoprolol as well and went down to the
Yes, because when they do go into atrial fibrillation, and then plus all of the comorbidities like heart failure patients, there are other reasons for them to be on the beta blocker. But when they do go into atrial fibrillation flutter to control the rate, the beta blocker will be the choice.
So it's not required to be in combination, but it can be used in combination. And something I forgot to mention earlier is, and Alex alluded to it, is that so amiodarone and dofetilide or Ticasin are the only agents that are really recommended in patients who have heart failure. The other agents are not, and some of them, particularly the class 1C agents, have shown, or 1 agents in general, have shown increased mortality in patients who have severe heart failure. And so the recommendations in patients who do have concurrent heart failure with an arrhythmia would be amiodarone or dofetilide. So that's another reason that we
And
choose
if you look at
them.
the studies that are very costly population, especially heart failure, they are readmitted repeatedly because they are in arrhythmia. That's what this admission does make.
Excellent. So then we are essentially taking it at the beginning and hoping that it works for them so that we can keep them out of the hospital more. Good.
Absolutely. And so sotalol is a similar medication in regards to the fact that patients need to be admitted to the hospital for initiation of this drug. And then similarly, we need serum creatinine. We monitor potassium and magnesium levels just to watch for drops, because if potassium levels are below 4, magnesium levels are below 2, we have an increased risk of QT prolongation and possibly torsades from that, and so those are things we monitor closely. But similar to Ticasin, we give this medication, and then 2 hours later we would do an EKG to monitor for prolongation. And with this agent, the starting EKG should show a QTC less than or equal to 450, and then we would stop the medication if the QTC was beyond 500. But again, there's some flexibility there depending on, what EP's weigh-in might be in regards to the safety of that medication for a particular patient. But sotalol infusions, if it's given IV, it is available IV or PO, but infusions are needed to be given over 5 hours, so that's an important piece for nursing.
Last time I tried to get sotalol, it was the past 2 years.
Oh, sure.
Yeah, I'm not sure. I've never seen it.
We haven't
It
seen it
is
either.
listed as IV.
Okay. Okay. So we don't have it.
Thankfully.
And then the oral medication, formulation of this medication of sotalol it's important to separate from any antacids, so especially ones that contain magnesium and aluminum. So if patients are on antacids,